Thank you very much, and thanks again, Valentina, for putting on such a fantastic, high-quality meeting. I've heard nothing but rave reviews last night and this morning, so congratulations. No mean feat to do it. It's tough enough to do a meeting with an entire organizing committee behind you as a national society. It's rather harder to do it as a one-off, as a first meeting. So I'm going to talk about some of the newer treatments for fecal incontinence. I think the way to think of how to treat fecal incontinence in this day and age, and I'm glad that Prof. Mather put in the anatomy slide because I didn't do that. So we start out one notch above. And I think the way to think of it is repair as one option. Within repair, you have sphincter repair and post-anal repair. Not that anybody does post-anal repair anymore. I may have been the last to publish on it about 25 years ago, and our success rate at that time was about 31%. Low morbidity, but not much better than placebo. Sphincter repair, which I'll touch upon. Then augmentation. And there's a variety of options for augmentation with injectables. Talk about that a little bit. Radiofrequency remodeling we'll touch on. Then there's replacement therapies, which have had a real flurry of activity and have now sadly kind of waned again. We had for many years the graciloplasty, which was based on Pickrell's work in children with imperforate anus, and then subsequently modified by Norman Williams at the Royal London, or at that time it wasn't Royal, it was just the London. And then we had also Cor Baton and Maastricht in the Netherlands, and Cavina in Pisa, Italy, with the same. So about 3 different places at which this developed, but that came off the market. We have the gluteoplasty, which isn't really too often practiced at all, but there's a few people around the world who do that. Then the artificial bowel sphincter and the magnetic anal sphincter, we'll touch on those. So you have so far repair, augmentation, replacement, and then stimulation. And that, I think, is really the hot ticket item these days. And ultimately, we still have diversion. And the only way that's changed is in addition to the standard stoma, we now also have the procedure, again, that Norman Williams likes, the Malone antegrade procedure for enemas. So overlapping sphincter repair is done in one of 2 ways. Either it's done the way the gynecologists do it at the time of injury, which is, generally speaking, just sewing the muscle to the muscle with a couple of chromic catguts, or if it's a delayed repair, they tend to excise the scar and do a direct sphincter apposition, as opposed to the way we like to do it, as shown in the diagram, where we deliberately preserve the scar and use it to anchor sutures to create an overlap. So this was really the only option we had before the post-anal repair, this option and diversion, till this flurry of activity. And the only trick about sphincter repair, the only little nuances, is how tight do you make it, and generally as tight as you can that it's not obstructing. There's not a lot of science behind that. What do you do with the skin? There's a high rate of infection. I tend to leave the center open, as is shown in the one diagram here. I just leave this little port in the center open for drainage. But the important part is the scar is preserved. Now, short term, we had some very good success rates with it, and you can see back in the early 90s, quite a few of us were publishing success rates in the 70s, so no reason to abandon an operation with success rates in the 70s, but we were just sort of figuring out the Parkes-McPartland method of sphincter repair at that time. But you can see what happens when you fast forward 20 years and you look at results from around the world. So you have UK results, these are Cleveland Clinic, UK again, you've got results in, this is in Serbia with Zoran Krivokapic and others, that there's this trend line down. And sphincter repair is not really a durable operation. So the way I counsel my patients now, if they do have a sphincter defect, I say one option is to fix this defect, but it's going to be a temporizing maneuver. So you probably do have a 70 to 75% chance of initial success, but by 10 years you're going to need something else done because it's not going to be a durable option. Some people say that's fine, and others say, well, what else do you have? And then we talk about some of the other options. So one of the simpler options is augmentation. And this slide shows some of the options here with augmentation. This one is a carbon bead that we've used for a while, injecting in the submucosa. It's a micropyrolytic carbon bead. bulk up the area. The problem with these beads is they became almost like thrombosed hemorrhoids, and a lot of them had to be excised, and we abandoned that. But there's a lot of things from this general part of the world. I think the late Ahmed Shafiq had the largest experience of anybody using autologous fat as well as PTFE, and this was kind of clever because it's a 2-for-1. You say to the patient, we're going to do a little body contouring, body sculpting, fat loss, and at the same time we're going to augment your anal sphincter. And he had pretty good results, but I don't see that being repeated in many places. Most of these series show modest improvements. They don't tend to show dramatic improvements, but they tend to show modest improvements in incontinence score. And as you go down the list, what you come to is the one that's really been the most actively marketed lately. Oliver Schwandner, one of our alumni, who's worked with Hans-Peter Bruch and is in Lübeck, Germany. And Oliver looked at this hyaluronic acid and found, again, it's not dramatic, but it is an improvement. And it's something that might be used for moderate incontinence, not for an incontinence score of 20, but somebody with an incontinence score in the sort of 8 to 12 range is probably best, because you can make people a little better, but you're not going to necessarily cure them. Recent systematic review of these implants, relatively recent, you can see one nice thing is the morbidity compared to a lot of the other procedures like graciloplasty, artificial bowel sphincter, and the like. The morbidity is quite low with over 1,000 patients here. This is the carbon beads, the Durasphere, the PTQ, Permacol's been used, all kinds of things. Long-term success is really all over the map. And that's something in this panel we have in common with fistula surgery. I mean, you've got all over the map kind of success rates. I personally like radiofrequency because I understand why it works and because it's a different mechanism of action. The injectables serve to bulk. It is creating a smaller outlet, and that's all it does. You're putting in filler to try to make the outlet smaller. Maybe it improves sensation. Radiofrequency seems to be a completely different mechanism of action. The way it works, there's a handpiece and then a transparent anoscope. And on that anoscope are markers that are set 5 millimeters apart. And out the bottom come 4 little electrodes. And so those electrodes, when the handle is pulled, those electrodes lock in the external position such that each one pierces the mucosa into the submucosa and the internal sphincter. And then you step on a foot pedal, which allows, and you can watch it on this clock here, 60 seconds of energy application. And the machine carefully monitors the surface temperature, the deep temperature, and the impedance. And if the temperature gets too hot, or if the impedance gets too high, that electrode will cut out, and you can elect to start over or go with just 3 electrodes. It keeps track of how many applications you've done. There's a constant cooling of water, so that there's 3 little attachments here. One is a fiber optic light cord. One is irrigation to keep cool, and one is suction, so there's not water pooling. And the way we did the trials is we started with these 4 electrodes, 0.5 millimeter below the dentate line, and then we went dentate line, 0.5, 1.5, 2, 2.5, up above, for a total of 5 energy applications in 4 quadrants, so a total of 80 tiny little punctures by these electrodes. And you can see the results of these different studies. The procedure was first done by somebody named Takahashi from Mexico City, who came in with pretty impressive results. And we do know from a lot of studies, including in the Netherlands, some of the larger scale studies in the Netherlands, that if the incontinence score drops to 10 or below, the patient has a statistically significantly improved quality of life compared to a score above 10. And that's been shown many times in many languages, but the first time was in the Netherlands. So they managed to achieve that here. We did a trial at the 3 Cleveland Clinic campuses. At the time, the 3 were not Abu Dhabi, Cleveland, and Florida, but it was 2 places in Florida, Weston and Naples, and Ohio. And at those 3 campuses, we didn't see quite that dramatic change, but we did see an improved quality of life anyway. Then Takahashi went on to do a longer follow-up, and so on and so forth. But as time went on, we didn't see quite the same dramatic improvement in these patients, but nonetheless, we did see improvement. The thing I like about it is I understand how it works now, and that's due to the work from Professor Mariana Barrow, who's been presenting at this meeting. Basically, we worked with Roman Herman from Krakow, Poland, and created an incontinence model in 12 pigs, and then either treated the pigs with radiofrequency or not. So we had untreated, we had normal sphincters, we had injured sphincters, we had treated sphincters, and then we had her and one of her colleagues who were blinded to the tissue blocks try and figure out what was happening. And it's very interesting what was happening is the radiofrequency energy was causing a differentiation in stem cell direction, if you will, so that a lot of the fibrosis was being converted to smooth muscle fibers, and smooth muscle fiber bundles were being made longer. And so you can look at all of her particular machinations. The collagen type was being changed, smooth muscle bundles were being improved upon by height and by width, the septal width was decreasing, which meant less fibrosis. So there was a lot of things going on that explained it. However, it takes 6 to 12 months for this to accomplish. This is not overnight. So when I apply this therapy, I tell patients you're not going to expect a change for 6 to 12 months. And it certainly isn't for everyone, but it's a nice option. Dynamic graciloplasty, I already alluded to it. This was probably the most complex operation that I ever had to learn because there were many branch points. Do you divert the patient or not divert the patient? Which leg do you use? Then which way do you wrap it? The muscle, alpha, gamma, or epsilon, which basically has to do with the way you turn the end. Do you anchor the tendon to the ipsilateral or contralateral ischial tuberosity or to the subcutaneous tissue? How tight do you make it? Do you tighten it with the legs adducted or abducted? Then do you stimulate the nerve or do you stimulate around the nerve? And do you start stimulation at the time of the wrap or wait a while and let it heal? What type of frequency program do you use to stimulate the muscles? And for a variety of reasons, it's no longer on the market, in part due to the complexity. But when it worked, it worked quite well. And basically, the principle of the operation was to convert the rapid twitch, easily fatiguing fibers of the gracilis to slow, tonically contractile fibers that would not readily fatigue and keep the anus shut, so that the patient would have a shut anus and then take a magnet over that little stimulator, which was located on the front of the belly, and just touch it, and it would open the sphincter and the patient could evacuate. And you can see the results of the different studies. We had, this was a multi-center, multinational study. This was a different one. A couple of large studies, and success rates were reasonable in many cases with different stimulation, but the complication rates were just exorbitant, and virtually every single patient had multiple reoperations and failures. So for a while we went to the artificial bowel sphincter, which was FDA approved in 1999, but unfortunately 2 years ago was withdrawn from the market. It was a pretty clever device. It was liberally adapted from the urologists for the artificial urinary sphincter. So there's a cuff, and we're hoping it comes back, because there was a cuff here that held basically between 3 and 5 cc's of fluid in most people. That attached to a pump, and the patient would pump. Every time they pump, half cc of fluid would go out of the cuff into the balloon, which stayed in the space of Retzius. And then over the course of the next 3 to 5 minutes, the pressure in the balloon would refill the cuffs. The patient would regain continence. And that operation, you know, is pretty straightforward, but again, unfortunately, a high incidence of infection. So when we look through the literature at different explantation rates, you see that they're pretty high. When they function, when they work, patients did well. I mean, you have a lot of patients, probably 60 to 70% of patients with great continence, but unfortunately a very high percentage of failures. Following that operation was the magnetic anal sphincter that Paul-Antoine Lour in Nantes, France really championed, a series of beads. This was originally made by a company in Sweden, and then it sort of bounced around to a few different companies. Most recently it was acquired by Johnson & Johnson, and immediately after they acquired it, they decided not to market it. So it is FDA approved, but not on the market, which is rather unfortunate because, again, I think it's a good option for patients. And it worked by, you didn't need a magnet, didn't need to carry anything externally, don't need to pump anything. It would work as a passive device where the magnets would open and close when the patient went to evacuate. And you can see it's a fairly straightforward operation, one incision in the anovaginal septum or between the testicles and the anus in that area, in the perineum, anterior perineum. But it does have an Achilles heel again, as did the artificial bowel sphincter, of a lot of infections. When it lasted, the success rates were pretty good. And this is a very recent article, very contemporaneous article, with significant improvements in all 4 of the fecal incontinence quality of life, significant improvement in continence, but unfortunately not commercially available again. And you can see reasonable success rates, greater than 50% reduction in fecal incontinence up to 5 years in these patients, significant decrease in weekly incontinent episodes, weekly incontinent days, Cleveland Clinic incontinence score, tremendous improvement, which did not wane with time. So that leaves us surgically with sacral neuromodulation, putting in a quadrupolar electrode into the third or fourth sacral foramina. Most people would have a preference for one or the other, percutaneously implanted. You can see the series that got us FDA approval was 120 patients. And you can see that the weekly incontinent episodes decreased. There's 3 different ways the statistics were done. I'm not going to go into them, but suffice to say, if we look at the improvement, it's anywhere 65 to 75%, depending on which statistic was used. And graphically, you can see major reduction in weekly incontinent episodes, weekly urge incontinent episodes. And we know from studies we've done nationally with the Nielsen Corporation of about 7,000 women nationally, that the biggest bother of incontinence is urge. It's the need to go to the toilet quickly. Fecal incontinence quality of life significantly improved. Looking at a meta-analysis here, relatively low morbidity compared to graciloplasty, artificial bowel sphincter, and magnetic sphincter, with big improvements in most of these areas. We start to expand how we're using it. Carlo Ratto looked at this area. What about if it's a sphincter defect? Seems initially we thought it augmented muscle pressure and it wouldn't work, but it turns out that's not actually the case, because even with sphincter defects, we still have major improvements. That score clearly drops to below 10, so that goes with significant improved quality of life. And when you follow up these patients in a variety of different studies, 36 months for the most part, you see incontinent episodes per week. You see the median score before, after. Dramatic improvements in virtually all of these, even out past 36 months. And we have studies even up to 5. One of our alumni, Donato Altamare from Bari, Italy, has 10-year data now. Klaus Matzell has 10-year data. So what do we do with all of this information? Well, we don't have the choices we used to have, but basically if the patient has a sphincter defect, if they have neuropathy, you might not want to do a sphincter repair because they don't do as well. You may want to go more towards sacral neuromodulation. But clearly, if there's a defect and no neuropathy, definitely talk about a sphincter repair as long as the patient understands that it's a temporizing procedure. If the sphincteroplasty is done and it works, that's fine. If it fails, you have to figure out, did it fail because there's a persistent defect, in which case you go back to the beginning, or did it fail even though the repair is intact, in which case you're definitely going to this side of the algorithm. If you're in this side, you either have a failed sphincter repair, the patient doesn't want a sphincter repair, or they're not a candidate because there is not an isolated defect, it's a multifocal defect, or it's so-called neurogenic or idiopathic incontinence. Some of these things are no longer available. And at the moment, the one that we're really left with is the stimulation procedure of sacral neuromodulation, or there's a non-stimulated graciloplasty, which in some patients occasionally will work, or injectables or radiofrequency on this side. And there's not necessarily a right answer, but I think if the patients had perianal sepsis, I would stay away from any radiofrequency or injectables. I think if the patient has spinal deformity, you might find sacral neuromodulation very difficult, but outside of that, there's not any guidelines. But you can see these things are dropping off as no longer available one at a time, and we're reduced in what we have. So we'll certainly go into these topics in more detail in February, but I'm sure we'll have a little bit of discussion later on. Thank you very much.